Hello, everyone. A very warm welcome to each one of you who has gathered today for this amazing session of Polaris Talks, and a warm good evening as well. And as we know, we as a team from Dr. Polaris are looking forward to be a constant part and parcel of your MBBS learning journey. And this is done usually in the form of lecture videos, notes, live discussions, animated videos, and many more of those kind, which can be seen in our app. Apart from that, we also are very careful and particular about letting out our hands in every possible way to help you students out there to deal each and every day of your MBBS learning journey. So myself, I am Dr. Aishwarya, content lead at Dr. Polaris, and I'll be your moderator today. With that, I would like to welcome our dear mentors and our dear sirs, Dr. Ryan Fernandez, Medical Director at Dr. Polaris, and Dr. Sanjit Bajpayee, Chief Academic Coordinator at Dr. Polaris. Hi, sirs.
Hi Aishwarya.
How are you
Hi
doing,
Aishwarya,
sir?
how are you?
I'm great. I hope you both are doing great there.
Yes,
Yeah.
yes, very excited to interact with our eager first year students.
Great. And the excitement is a little bit more, I feel, today because we are actually dealing something really which they are looking forward for, right?
Yes,
Like one of the most important things that they are looking forward for, like something related to academics. We have gathered enough information for all our dear students from all our 7 chapters of Polaris Talks, like the initial orientation, ragging, the textbooks, the exams, everything. And now, after all those, we are stepping onto the academic session, and we're actually paving a right way, I feel, for everyone. I am feeling jealous of them, really, sir, because they're getting some amazing platforms, I must say. I wish I had mentors like you both when I was in first year. What about you, sir?
No, we feel anatomy has been one of the most kind of a most difficult subject to deal in the first place because most of
Yes,
the times what the kind of learning goes in which we kind of realize the importance of this subject very late. So that is why we came up with taking up
okay,
anatomy and starting right from the beginning. First page of anatomy, that is general anatomy, and this is going to go all the way up till advanced level, where we will be teaching till the end of what exactly anatomy means and how it is going to help you in your clinical correlates as well. That what exactly in the everyday life you will see. And this is how we have framed these chapters, and we are going to give you the crux of what you should know and how you should actually link those dots in order to get to a diagnosis. Right, Ryan sir, I think over to you so that you can take over and guide the students for the very first chapter of anatomy, that is about introduction and general anatomical terms.
Hi, Ryan, sir. I think sir is really set to, give a lot of enlightenment to our dear students with the topic. So, before I hand over the whole, area to our dear Ryan, sir, I would just like to make a point to our dear viewers. A very warm welcome to all the attendees today. Guys, this is an amazing session. I assure you that is very much sure. You guys can be very sure of that. But apart from that, keep what I would like to say is keep understanding what Sir says at every point of time, because this is what you're going to be seeing throughout your journey hereafter. And wait till the end of the session because we have amazing prizes and amazing suspenses and surprises coming up at the end of the session. Like if I'm not wrong, last time we gave a free subscription to one of our attendees, right, sirs?
Right.
yes,
And this time we have
Yes,
something exciting for everyone. It's a
yes,
game
yes.
that will be by the end, and we will see how much of our talk and how much of introduction has actually helped the students and how well they can
Great,
clinically correlate. So there are a lot of
great,
clinical
great.
scenarios coming up post this lecture. Stay tuned.
All right. So over to our dear Ryan, sir. So the baton is yours. We are
yes.
eager.
Before I start, I would like to ask: is the slide visible?
Yeah,
Yes, yes,
it's
yes,
visible.
sir.
Yes.
Yes.
Okay, so like Dr. Aishwarya said, it is so exciting to talk about anatomy. And like Dr. Sanchit said, we are actually going to the first page of anatomy textbook. Very often, this is the page which most of the colleges, I think, even don't bother taking. because they think that it is not very important, only for us to realize later that whatever is taught in this first page, you will be talking about it for the rest of your career, in terms of the different terminologies that are used in anatomy. So what a wonderful way to begin this journey of anatomy. And let me say that whether colleges or professors think that this topic is important or not, it is one of the competencies mentioned by NMCs, and it is in fact the first one mentioned by the NMC, and it is there in your curriculum, and so obviously it is important. So let's begin. The moment we talk about anatomy, first thing before we talk about anatomy is what are the subdivisions of anatomy. So we know that you can see here there is a huge list of subdivisions. First one being cadaveric, which I'm sure by now all of you have entered your dissection halls, begun the dissection process, and started at least dissecting the upper limb or the thorax area. So that is the cadaveric anatomy. Living anatomy. What is this living anatomy now? Is there something called as living anatomy? We've heard of dissecting cadavers. What about dissecting the living? Yes, the living anatomy is something you will come across when you reach your second year or third year. Once you enter the operation theater, once you enter the subjects of ENT, ophthalmology, surgery, where while a procedure is being done, while a surgery is being done, while some defect in the normal anatomy of the individual is being corrected, your professors will show you different structures, the arteries, veins, muscles, and that is known as the living anatomy. Then comes applied anatomy. What is applied anatomy? Applied anatomy is when you take this knowledge that you get from your cadaveric anatomy that you're doing now and then apply it to your day-to-day life. For example, we know that Rishabh Pant recently met with a major accident. He is diagnosed to have multiple ligament tears, which will probably take a year to heal. Now, this is what is known as applied anatomy. You know that there are ligaments around the knee, which you would have dissected during your anatomy. Then you take it, you investigate it, use MRI scans, and then you apply it to the individual, apply it to the patient, and that is known as applied anatomy. Then comes embryology. Oh, embryology is one topic most students love to hate. It is the study of the anatomy from the origin of the embryo. So fetal part of anatomy, and that is known as embryology. Then comes neuroanatomy. Anything related to the nerves, the brain is known as neuroanatomy. Microscopic anatomy, you're spending your dissection morning hours in the dissection hall, then you're going to your practical sessions in the afternoon, spending time under the microscope, looking at some white, blue and pink structures, and that is nothing but the microscopic anatomy where you're seeing the tissues under the microscope. Surface anatomy. This anatomy refers to that part of the subdivision where you are not seeing the structure, but you are assuming that the structure is below. For example, surface anatomy of the lung. You know from where to where the lung is extending. So from the skin itself, you have a look saying, okay, the lung extends from here to here, and this is known as surface anatomy. Lastly, coming to radiological anatomy. Yes, you have studied cadaveric anatomy, living anatomy. What about the radiological anatomy that a radiologist can see? A radiologist will use an ultrasound and see the liver. It looks like a grainy black and white image that nobody else would probably understand. But understanding that part of the anatomy is nothing but radiological anatomy. So these are all the subdivisions of anatomy that are present. Then coming to anatomy proper. What exactly is anatomy? It is the study of the structure of the human body. Now just look at yourself there. Nice, fresh, you all are sitting there, sitting or standing. I don't know how you all like to listen to a lecture. So you can see that your body is divided obviously into a head, neck, trunk, and limbs. All of us have this head, neck, trunk, and limbs. That trunk of yours is further divided into thorax and abdomen. And the abdomen of yours is further divided into abdomen proper and the pelvis. Now, Netter's atlas, and an atlas is something you should have with you all the time along with your textbook. And this is Netter's atlas. And you can see that the human body is divided into the head, which is not visible here, neck, the trunk, and the limbs. The trunk is further divided into the thorax and the abdomen. And the abdomen is further divided into the abdomen proper, and the part where the pelvic bones begin, the lower part of the abdomen, that is the pelvis. 1 second, that is the pelvis. Yes. Next, we move on to the anatomical positions of the body. Another very important point: stand up straight in your places wherever you are. Keep your hands by your side. Keep your feet together. Let your palms be facing upwards or facing forwards, with your thumbs facing sideways. This is known as the anatomical position of the body. So that is, the body is standing upright, the upper limbs are hanging by the sides, the palms of the hands are directed forward, the head and eyes are directed forward, the lower limbs are parallel with the toes pointing forwards. So this is what is known as the anatomical position. You can see it is an individual standing straight with the eyes pointing forward, the limbs, the upper limbs are hanging by the sides with the palm facing forward, the thumbs are facing sideways, and the toes are pointing straight forward. So this is known as anatomical position, which will be referred to often. Now, once you know what is the anatomical position, these planes, anatomical planes, are something that you will be talking about a lot, not just in your anatomy, it will be later when you come to your clinical side as well. So we have different planes: median plane, sagittal plane, coronal plane, and transverse plane. Now, median plane, imagine you're standing there. Now, this is just imaginary. Whatever I'm asking you is to imagine. Please don't take offense to anything that I say. Imagine that you're standing straight in that anatomical position, and somebody comes, stands in front of you, takes a chopping knife and chops you right in the center of your head, straight down your nose, straight down your abdomen, in the middle of your abdomen, up to your pelvis, such that you're divided into two halves, right and left half. This is known as the median plane. Now, sagittal plane is another name for median plane. So when this cut is right in the center, it is called as median. If it goes parallelly to the sides, then it is known as sagittal plane. The same cut that is in the center is known as median plane. If it's slightly to the either side of the median plane, it is known as sagittal plane. Now, the same thing, you're standing straight in the anatomical position. That person comes and stands next to you and chops you in such a way that you're chopped from above your face, and the anterior part of the front part of your stomach and chest is forward and the back part is behind. Then it is known as the coronal plane. And if he is standing in that same position and chopping you such that your upper half of the body is one part and the lower half of the body is another, known as transverse plane. If it was gruesome to imagine, we'll make it very simple. Again, from Gray's Anatomy of textbook, you can see the different planes now. This is the anatomical position: eyes pointing forwards, abdomen facing forwards, the toes facing forwards. Now, first coming to the median plane. The pink plane, the pink box is what is the median plane, what is dividing the body into the left half and the right half. Any plane that is parallel to this median plane, it might be somewhere here, which divides the body into unequal right and left parts, is known as the sagittal plane. So if that sagittal plane, the median plane is nothing but a sagittal plane which is in the center. Then coming to the coronal plane. Now, the plane perpendicular to the median plane is nothing but the coronal plane. I told you somebody is standing by the side of you and chopping you from the side. So this blue plane is the coronal plane, and when the green one, which divides the body into a upper half and lower half, then that is known as the horizontal plane or the transverse plane. So these are the basic planes of the anatomical planes that you should be aware of. No longer are you ever going to refer to your body as front of my body and back of my body. That front is replaced by the word anterior, back is replaced by the word posterior. Front of the leg is anterior, back of the leg is posterior. Then along with anterior and posterior, there are two terms that you should be aware of, that is ventral and dorsal. This is more in relation to the trunk. When you're talking anything related to the belly is ventral, anything opposite to the belly is dorsal. Again, we'll go to the image and we'll discuss. And in the hand, there are two terms that you should remember, and it's very easy. Instead of using this anterior and posterior, if this is my hand, the part that is the palmar surface, that is the anterior surface, will be known as the palmar surface. The back of the palm is posterior, and that will be known as the dorsal surface. Same thing on the foot. You're planting your foot on the ground. So the part which comes in contact with the ground is the plantar aspect of the foot. The part that is behind the plantar aspect is the dorsal aspect of the foot. Palmar aspect of the hand, dorsal aspect of the hand. So again, if you see this, this is the palmar aspect of the hand. The part behind the palmar aspect is the dorsal aspect of the hand. The person is standing here firmly on the ground. The part which is in contact with the ground, the part of the foot which is in contact with the ground is known as the plantar aspect of the foot. The part opposite to that is known as the dorsal aspect of the foot right here. Then there are two more terms, proximal and distal. Again, gone are the days when you will be using the word nearer and farther or further away. Anything that is closer is known as proximal. Anything which is further away from a joint is known as distal. Now here you can see that this is the wrist joint, this is the elbow joint, this is the shoulder joint. If I want to talk about structures that are close to the shoulder joint, anything that is close to the shoulder joint, like this area, is called as the proximal part. Anything that is far away from the shoulder joint is known as the distal part. If this is the elbow joint, anything close to the elbow joint is known as proximal. Anything far away from the elbow joint is known as distal. So that is proximal and distal. Next, we come to another terminology that is often used. This is something that I think you won't get confused. Anything closer to the head is known as cephalic. Anything away from the head is known as caudal. Now, why should we use a term? Now, suppose you're talking about the esophagus. The esophagus is long. It starts from the neck. It goes up to the abdomen. You want to refer to the upper part of the esophagus. You don't say that the upper part of the esophagus. You can call it as the cephalic part. Caudal is closer to the tail. If humans had tail, then you would say closer to the tail. So the part lower down will be known as caudal. So closer to the head is cephalic, away from the head is caudal. Now we spoke about the planes, the median planes. Now there are, based on these median planes, there are some things that you should remember. So you know that this is the pink line, pink box is the median plane. So anything that is closer to the median plane is known as median. Any structure that comes close to the median plane, median end plane, is known as a structure that is medial. Anything that is far away from this median plane, it is known as lateral. So that is how you will be referring to structures in the body anymore. Anything that is in the center becomes medial. Anything that keeps going away from the center, from the median plane, it keeps becoming lateral. So medial, lateral. External and internal. Again, this is self-explanatory. Whichever is closer to the exterior is external, which is inside is internal. Which is closer to the skin is superficial, which is deep to the skin is deep. So medial, lateral, external, internal, superficial, and deep. And when we are talking about the organs in the body, for example, like the liver, the part which is external, which is superficial, is known as external. The part which is deeper, onto the deeper side of the structure, is known as internal. So whichever is closer to the skin, now this is skin, the subcutaneous tissue fat will be superficial. The bone, which is deep inside, is deep. So those are the other, some simple terminology. A joint is something that you don't need a anatomy textbook to know about. It is the site where two or more bones come together, and that is known as a joint. Why are we talking about joints here? Because next we come to movements, and these movements are something I really want you to focus on, because for the rest of your MBBS, MD, MS, DM, NCH, wherever you go, you will be talking about these movements, and understanding these movements are very important. So movements, we spoke about joints because all movements should take place at the joints, and these movements are described in the sagittal and coronal planes. Now again, you know that this is a coronal plane, the blue one is a coronal plane, the pink one is the median plane, which is a type of sagittal plane, and anything parallel to that is known as sagittal plane. So the first movement that you should know is flexion and extension. What is flexion? What is extension? Flexion is nothing but reducing the angle between a proximal part and a distal part. Anything that reduces the angle between a proximal and distal part is known as flexion. Anything which increases the angle between the proximal and distal part is known as extension. Keep this in mind. It's a very, very simple explanation. Which decreases the angle is known as flexion, which increases the angle between the proximal and distal part is known as extension. So if you see this image, now you have done this exercise a lot, bending forwards and then either standing up straight or moving backwards. So this bending forward movement is happening at the hip joint. There is a reduction in the angle between the upper part of the body and lower part of the body. So that is very simple flexion. Same thing, you are moving from this flexed position and moving up backwards. You are increasing the angle between the proximal and the distal part, and that is known as extension. So flexion, extension. This part now you can see that the movement is straight and sideways. What are you doing? You are reducing the angle between the proximal part and distal part, and this is known as lateral flexion. If you are moving to the right, it is known as right lateral flexion. If you are moving to the left, it is known as left lateral flexion. Now those are the movements in the trunk, or your between the upper part of your body and the lower part of your body. So this is flexion and extension. Now we come to flexion and extension in other parts of the body. So it's not just that the trunk moves front and back. We have shoulder joints, we have elbow joints, we have wrist joint, we have metacarpophalangeal joint, we have hip joint, we have knee joint, we have ankle joint. So movements occur here. So what is flexion? What is extension here? So again, bending movement that decreases the angle between the proximal and distal segment is known as flexion. The opposite of flexion, which increases the angle, is known as extension. Now look at this first image that I'm pointing to. This is the shoulder joint. Imagine this is the proximal part of the body. This is the joint here. Now when you're moving your hand forwards, your hand is coming forwards here, you're decreasing the angle between the upper part of your body and the lower part of your body, and this is known as flexion at the shoulder joint. The same thing, you're moving the shoulder joint backwards. It has gone backwards here, and that is known as extension, because you're increasing the angle between the proximal part and the distal part. Come lower down, come to the elbow joint. You're moving your hand, your forearm upwards. You're decreasing the angle between the arm and forearm. That is flexion. Now you move the elbow joint backwards. You are increasing the angle between the arm and the forearm, and that is known as extension. So you finish the elbow joint, come to the wrist. You are moving your wrist inwards. You are decreasing the angle between the forearm and the hand, that is flexion. You're moving it downwards, that is extension. You're increasing the angle between the forearm as well as the hand. Look at the fingers there. You're folding the fingers inwards, that is flexion. You're moving the fingers outwards, that is extension. So that is the upper part of the body. Now I'm sure most of you are sitting there on your chairs. Now look at your legs. Look at your legs at the hip joint. Isn't it bent there now between the hip and the thighs? So you're decreasing the angle between your hip, upper part of your body, and your thighs. So your hip is in flexion right now. Along with that, pay attention to your knee. So here it becomes a little tricky. When you look at your knee now, the knee is bent. What is it doing? It is decreasing the angle between your thigh and your leg, the lower part of your leg, but it is doing in the opposite direction, behind. So that is also flexion. So if you see this image, movement of the thigh upwards is flexion, movement of the leg backwards at the knee joint is flexion. Making the leg thigh straight at the hip joint is extension. Making the knee joint straight is extension. So that is the difference between hip joint and knee joint. So the movements occur in opposite direction. So now this part here, you can see the knee here and the lower part of the leg. The knee joint, the lower part of the leg is moving backwards. That is flexion. It is coming straight down and making the knee joint straight. That is extension, because in flexion, it was reducing the angle between the thigh as well as the leg. So very, very important concept to remember: flexion and extension in different parts of the body. What about your neck? You're sitting up straight there in neutral position. You move your neck forwards, bend it forwards. That is flexion. You're decreasing the angle between your head and your thorax. Move your neck backwards. That is extension. So flexion, extension at the neck. Move your neck sideways, just like how we spoke about in the trunk, where you are moving the entire trunk sideways. That is lateral flexion. Here also the neck is in lateral flexion. Right lateral flexion, left lateral flexion. You turn your neck to one side. If you're turning it to the left side, it is left rotation. If you're turning to the right side, it is right rotation. So neutral, extension, flexion, left lateral flexion, right lateral flexion, left rotation, and right rotation. Then we come to the wrist. I told you about the wrist. The next term that you should know is abduction and adduction. Again, a very easy concept to understand if you understand it rather than you by heart. We often talk about abduction, kidnapping. Kidnapping, what do you mean by kidnapping? The other word for kidnapping is abduction. You're taking something away from someone. You're kidnapping a person. You're taking a person away from their family. So anything that moves the joint or the structure away from the midline, known as abduction. Anything that is opposite to abduction, it is coming back to the median plane, is adduction. So at the wrist joint, remember, when wrist joint, we're talking in the anatomical position with the palms facing forwards. Abduction refers to the movement of the hand away from it. So it goes towards the sides of the thumb. The thumbs are facing sideways. So moving towards the side of the thumb is known as abduction. It is also known as radial deviation. Movement of the wrist towards the median plane. Median plane, movement of the wrist towards the median plane is known as adduction. Simple. Then we come to the fingers and toes. I'm not going to show you my toes. I'm going to show you my fingers. Now in the fingers, the middle finger becomes the median plane. So you are moving the other fingers away from the middle finger. You are kidnapping the other fingers away from the middle finger. Abduction. You are moving the fingers close to the middle finger. Adduction. So same thing applies to the toes as well. So again, in the picture here, you can see if the wrist is moving away from the midline towards the thumb, then it is abduction. If it is moving towards the little finger, then it is adduction. It is also known as radial deviation because the radius bone is here, and ulnar deviation because the ulnar bone is here. This is abduction and adduction at the fingers. I already showed you abduction and adduction. Now you remember, you should know that you have a thumb as well. Now this thumb along with is a little separate from the fingers because it is at right angles to the fingers. So flexion and extension, abduction and adduction is a little different for thumb. So you want to reduce the angle between the proximal and distal part. So flexion in the thumb is inward movement of the thumb, that is flexion, and extension is outward movement of the thumb. You are reducing the angle between the thumb and the palm, flexion. You are increasing the angle between the thumb and the palm, extension. Abduction and adduction. This is the neutral position. So you are moving your thumb away from the other fingers. So abduction. You are bringing the thumb closer to the other fingers. That is adduction. And then your thumb has another movement which is possible only because it is the thumb. That is, you can count. We always count like this, right? 1, 2, 3, 4, and this is known as opposition. Meeting the thumb with the other fingers is known as opposition. Flexion, extension, abduction, adduction, opposition. Then we come to another term known as rotation. That is the term applied to the movement in which the part of the body turns around its own longitudinal axis. So here when you're talking about rotation, you have to remember two things: pronation and supination. Rotation of the radius on the stationary ulna. Now, this is my anatomical position here. Now let me keep the ulna stationary. I will move only the thumb, that is the radius. The radius, if the anatomy of the forearm has not been covered, the bone that is along the thumb is known as radius. The bone that is along the little finger is known as ulna. Now I'm sitting here in my anatomical position with the palms facing forward. Now I will not move the little finger, I will move only the thumb. So I'm moving the thumb inwards. Now this is not the anatomical position, and this movement is known as pronation. The same thing, I'm moving outwards. I'm keeping the ulna, the little finger stationary and going back to the anatomical position. So it is known as supination. So when you know we classical singers keep doing this movement, actually what they're doing is pronation, supination, pronation, supination, pronation, supination, pronation, supination. So that is known as pronation. And we spoke about rotation. You want to move this bone joint around the axis. So whenever now, don't forget about this part, forget about the leg here. Concentrate on the right arm of this individual. So now the right arm is moving laterally and then moving medially. So it is rotating. Lateral rotation, medial rotation. Going away from the body, that is lateral. Coming towards the body, that is medial rotation. Now same thing, if you see in this hand, in the left hand now, by now we have discussed everything, so you should be able to say that now this hand is in the anatomical position. Now it is, the hand is moving, the arm, we talk about hand is only the fingers and the palm, that is the hand. Now the entire left arm is moving away from the body. So something that is moving away from the body, something that is being taken away from the body is known as abduction. So this arm is abducting at the shoulder joint. It is coming towards the body. It is adducting. So abduction, adduction. Now same thing if you are looking at the leg there, right leg. Now if you are standing straight and just moving your leg laterally, so you are moving your leg away, that is abduction. You are bringing your leg closer and standing straight in attention, that is adduction. What is happening here is not abduction. You can see that the leg rotating just like the upper limb on the right side, the lower limb on the right side is rotating. So this is known as lateral rotation. And when the leg comes and turns inwards at the hip joint, it is known as medial rotation. So medial rotation, lateral rotation, and the leg comes inwards, it is medial rotation. So rotation also is important. So you can see all of you all know about cricket. You have either played cricket or watched cricket. One movement that occurs there. Now this bowler is going to bowl. One full circle he will make at the shoulder joint, and this is known as circumduction. Anywhere where a circle can be drawn by a body part, that is known as circumduction. A very common question asked during practical exams in the afternoon during your viva, during your university exam. So that is circumduction. Now you're sitting there, you're tired. Some of you are becoming impatient. When this class will get over, you're moving your foot. Once you're moving your foot inwards such that the sole of your foot is pointing inwards. And once the sole of the foot is pointing outwards, inwards, outwards. So this movement is known as inwards, inversion, outwards, eversion. Inwards, inversion, outwards, eversion. That movement occurs at the ankle joint. And the last movement that you should know is the movement of the jaw. You're moving your jaw forwards, and that is known as protraction. You're moving your jaw backwards. So you can see here, he's pulling his jaw backwards, that is retraction. He's moving his jaw forwards, and that is protraction. To summarize everything that we have discussed today, this one image is more than enough. So you can see now we discussed about the planes. Now, first thing that you have to notice is this individual is in the anatomic position with the eyes pointing forwards, the palms facing forwards, with the toes facing forwards. I hope you all are keep an eye on the pointer. So that is the anatomical position. The pink box is the median plane, which divides the body into the right half and the left half. Any plane which is parallel to this median plane is known as the sagittal plane. The plane which is exactly perpendicular at 90 degrees to the median plane is known as the coronal plane, which divides the body into the front and the back, what is known as the anterior and posterior. And with a plane, the green one, the plane which divides the body into an upper half and lower half is known as the transverse plane or horizontal plane. So the planes are done. I told you no longer are you going to call this the front of the body and the back of the body. This front part of the body is known as anterior, and this back of the body is known as posterior. If it is the trunk, you will call it, the belly part is called as ventral, and the posterior part is called as dorsal. In the palm, it is called as palmar, and the back part is called as dorsal. In the foot, the part which comes in contact with the ground is called as plantar. The part opposite to it is called as dorsal. So those are the different parts there. Then we come to the part which is closer to the head is called as cranial. The part which goes away from the head is called as caudal. Now look at this arm here, the left arm of the image. Now when the arm is rotating outwards, it is known as lateral rotation. When the arm is rotating inwards, the thumb goes inwards, it is medial rotation, also known as pronation and supination. Thumb is moving inwards towards the body, it is known as pronation. The thumb goes back to the anatomical position, it is known as supination. So pronation, supination. If it is happening at the shoulder joint, it is known as internal rotation and external rotation. So it depends on the joint. So movement at the inward movement at the shoulder joint is called as internal rotation or medial rotation. The outward movement at the shoulder joint is called as lateral rotation or external rotation. When it is happening at the wrist and the forearm, it is known as pronation and supination. Same thing now when you look at the leg, I told you when the angle between the trunk and the thigh is reduced, it becomes flexion. When the angle between the trunk and the thigh is more, it becomes extension. When the angle between the thigh and the leg posteriorly is reduced, it becomes flexion. So backward bending at the knee is flexion. When you're hopping, that is, you're flexing the knee. When you're again coming back to standing position, you're extending the knee. When the foot goes, the plantar surface of the foot, the little toe goes inwards, goes towards the midline, that is known as inversion. When the thumb, the great toe goes outwards, it is known as eversion. So these are all the movements, these are all the planes that we can summarize in one slide. Next, I want to give one general instruction for dissection. We all know that you're doing dissection right now. Dissection is something that you have to take very seriously. It is a process of freeing the structures from the surrounding tissues and demonstrating them clearly. You're probably dissecting the upper limb right now. You must have gone through the skin into the subcutaneous tissue. By now, you must have reached some of the muscles. I'm sure the muscle, the biceps femoris, they must be discussing the biceps femoris. So that dissection you take very seriously. I'm sure you are having a scalpel with you. Remember, the scalpel has two parts. One is the handle known as the BP handle or the Bard-Parker handle. When the blade comes onto the Bard-Parker handle, it is called a scalpel. Otherwise, it is only a Bard-Parker handle. There is no scalpel without a blade. At least two pairs of forceps you're carrying, hook to seek out any structures like nerves, hand lens if you want to see any deeper structure, and torchlight. When you're dissecting, there are some terms that you should know. This is the last slide, and the terms that you should know are, first one is dissection. So you're dissecting, you're nothing. I'll give you an example. Suppose you're doing an appendicectomy today. You have come to the operation theater. These are the terms that you should know. You're dissecting. You have put an incision on the skin, in the subcutaneous tissue. You have reached the muscle, whatever muscle. We were not going to mention the muscles now because you have not yet reached there. You're dissecting each structure. That is known as dissection. Then there is a term called as retraction. Now you're dissected. You have reached the muscle. You want to go deeper. So you can't go deeper unless you pull the muscles apart, and that is known as retraction. Pulling the muscles apart is known as retraction. That is what you will be doing now. When you go in the forearm, you want to see the nerves there, you will retract the muscles away from each other. Reflection. Now suppose you have cut the muscle. This is the muscle you have cut. Rather than pulling them away, you are opening them up. That is known as reflection. You are reflecting the muscle upward as if you are opening up packet. That is known as reflection. Pulling them apart is known as retraction. Separating them is known as reflection. Now we are talking about appendicectomy. We have reached the appendix, and appendix has a artery which supplies it, known as appendicular artery. Without tying that appendicular artery, you cannot remove the appendix, because the appendix, otherwise the structure starts bleeding. So you will transect the vessel, you will cut the blood vessel, and that is known as transection. Whenever you're cutting a nerve, whenever you're cutting a vessel, that is known as transection. And then you want to only separate the appendix. Only the appendix should be there. There should be no fat around it. And that part, you're defining the appendix. You're isolating the appendix, and that is known as defining the structure. So these terms, as you're dissecting there, don't use terms like I'm cleaning the tissue. No, we are defining the structure. I'm not cutting anything. I'm transecting a structure. I am not pulling the muscle apart. I'm retracting the muscle apart. So dissect, retract, reflect, transect, define. So these are the terms that you're going to use. Now, I'm going to bring in Dr. Sanchit, because today's lecture is over and he has an interesting activity that he has planned here. So he says, let's see how we can apply what Dr. Ryan has taught till now. Over to you, Dr. Sanchit.
Thank you, Dr. Ryan. And I'm so happy that, you have beautifully described, I still say, one of the most difficult topics to understand in anatomy. And students, I would rather say this, that in spite of, having so much of knowledge later on in life, you still struggle with terms. Because if you understand, you have been graced with a profession which has its own dictionary. No other profession has its own dictionary. Doctors have a dictionary separately. So our talking terms are very, very different. So if I'm talking to Ryan sir, and if I say something that I went medially, I dissected this structure, only he can understand that. It's kind of a code that I'm sharing with him, and nobody else in the room can understand unless and until he's a doctor. That is the beauty. And anatomy has got so many terminologies, so many terms, that if you're friendly right from the beginning with these terms, then it will be very easy for you later on when you actually read subjects, right? So this is the kind of activity that we have, and that is what we are also doing on Dr. Polaris, that we are not just telling you the chapter, we also want you to ingrain that thought that how can you utilize whatever Ryan sir has taught today and use it in your daily life. So I have certain clinical scenarios for you, and I request Aishwarya to please, have students participating in it, because I want the students to actually come up with answers so that I could know that how much of you have understood this, and if not, then we'll be covering that loophole and making you understand that where and how things can happen, right? So I think Aishwarya, if you can also come in.
Yes, sir. I'm so excited for this.
Yeah. So I think we can have the hand raising session. So as soon as we have a question in front,
Before that, Dr. Sanchit, I have a question.
Yeah.
What will I get if I answer right? Is there any reward?
Yes, definitely there are rewards. I think Aishwarya will share the rewards with the student.
Then I am the first one to participate. Okay.
Yes.
Let's keep that a surprise. Let's see how the participation goes, and we'll see how it moves forward. And before I sir, can we go for a commenting section? Like, can the students comment their answers? Is that fine?
It can be fine. Or also we can do one thing. If they can, whoever raises a hand first gets the first chance to actually, because I want an interaction with the person so that we could know that how much of that thought has been ingrained.
And Dr. Aishwarya, as much as possible, we'll encourage them to talk. They will not talk in their classroom. They will not talk in their dissection hall. Let them talk here.
And that is why we want this kind of a student-mentor interaction. Yes. So that we also know how far this is what we are following.
If they are shy, they need not switch on the video, but definitely let them switch on the mic.
Yeah. Okay. So let's move on to the first clinical scenario. I think whichever student raises the first hand will get the answer, will get a chance to answer that. Fine. So you are a doctor who's posted in the ICU, and late at night you receive a call from the emergency straight away. It will happen a lot of times. And you are said from the sister in that station that a patient has come with severe vomiting and the patient is choking because the patient is disoriented and intoxicated. Now you rush to the emergency to see the patient, and as soon as you see the patient, you do a simple maneuver. Now this is common sense. Whenever we see a person who's intoxicated and vomiting, he would be lying straight and he's vomiting out and he's having that choking spells. In the figure, what is shown on the side, there is a maneuver that you do to save the patient's life. What did you perform over the patient to prevent the choking spells? A, you turn the patient laterally. Second, you turn the patient medially. C, that is flex the patient's neck. And the last option is you extended the patient's neck. So any of the students can raise their hands and actually tell us that what exactly you think that you did to save the patient's life. Anyone?
Yes,
can go ahead and come. And your answer, if they are wrong, that doesn't matter, because we want you to actually participate, and so that these thoughts actually ingrain that kind of a case scenario based learning. That is why we have kept these case scenarios. So as soon as you know, right, somebody is answering.
Yeah. Anyone who wants to answer, please raise your hands.
4 people have raised their hand.
Yes, we have the first person. I think there are a lot of people who has joined with a link from Abanti Banerjee. So I can see the first person who has raised hand is Abanti Banerjee, who is there in the first one. Can you please unmute yourself and tell us what is your name?
First come, first serve.
Yes, we have. Yeah, hello. Okay, we have someone. Abanti has answered third option, sir.
Third option. So you flexed the patient's neck. Okay. Anyone else who wants to correct it?
There are other people. Yeah.
First
Hello,
option.
Abanti.
Swati. First option.
Swati. Okay. Swati says it's first
Swati is
option,
saying
sir.
that you turn the patient laterally. Okay, Swati.
Yes.
Okay. Okay. So you turn the patient laterally. What made you think that this will help the patient?
Because if patient is placed laterally, it will not enter into the lungs directly.
Great. That is the answer that I was expecting, because that is a simple thing that you are saving the vomiters to go inside the airway. And that is why you want all the vomiters to just come out of the angle of the mouth and the patient is safe. Right? So
Yes.
Great answer, Swati. That is the right answer.
Excellent,
That is the
Swati.
first
Very
option.
good.
You turn the patient laterally, right? That is what Ryan sir said. Anything that is away from the median plane. So if you see, the patient is away from the median plane and it's completely turned towards the lateral side, right? So this is what exactly the first scenario is all about, right? So now we can move on. So congratulations, Swati, for getting it right. We'll move on to the second question. Right. So this is the second case scenario. Now, this is about an ENT OPD. You will be soon inside ENT, right? And this is a regular thing that goes on in ENT surgery, that a 55-year-old singer by occupation, and he has entered to the OPD, and he complains that he has a sudden change in voice. He was singing in a concert, he came back, he has sudden change in voice. The consultant who was sitting there, he said, okay, we will do a laryngoscopy. Now, specifically, laryngoscopy means that we are just putting a camera inside the voice box to see what is there inside. And he carried out that laryngoscopic examination over on the patient to assess the movement of the vocal cords. Now, if you just see that white shining thing in the center, what has been marked are the vocal cords, right? Which are, the patient is speaking something, so they are coming, they are joining together, and then the patient is breathing again, so they are again going far, right? Now, what exactly is the movement that is shown here in the picture? That is abduction and adduction, or flexion and extension, medial rotation and lateral rotation, or dorsiflexion and internal rotation. Anyone for that? So what exactly the vocal cords have moved? What is that called as?
Come on, guys, make me proud.
Yes,
Right.
I have someone answering one, option
Okay.
one. Can you
So who
please
is-
unmute yourself and let us know what is your name?
Abduction and adduction, ma'am.
Your
who is
name,
this? Can we
please?
know?
Swati.
Swati, great.
Swati.
Again, so I think Swati is the one who's sitting in the first bench of the class and she is listening very carefully. It's a great answer. Can you just tell us why did you think abduction and adduction and not flexion and extension?
Sir, like the doctor who is operating, like doctor is doing structures, like it is moving from the median plane, like far from the median
Correct.
plane.
That is the answer. So it is moving far from the median plane. So what is that called as?
Median plane far means it is taking away means abduction, and
Abduction.
getting towards is like adduction.
Adduction. So add means together, you join it, you come closer. Ab means you go away. Like Ryan sir rightly said, that if you abduct someone, or you just kidnap someone and you take them away, right? So
Yes.
this in vocal cords is simply abduction, where they open and go far apart, and adduction. So when I'm talking to a consultant who's on the side or my resident, I would say that just see the movement of the cords. They are abducting and they are adducting. This is my language that I'm going to share. I'm not going to say that they are coming close and they're going far, right? This is what the word should be. Great, Swati. So this is another right answer for Swati, and 2+ points to Swati right now. Okay, now let's come to the third question, the third case scenario. Right, very usual case scenario. A 30-year-old female patient has presented to the emergency. You'll soon be there in the emergencies as interns. And this patient has come with a history of fall injury. Now, precisely when there is a fall over the face, there is a huge swelling that is seen over the dorsum of the nose. Now, just to make it clear, this is the dorsum of the nose, the front part, what you're seeing here. There is a swelling here, right? And you performed an X-ray of the patient, okay? So you just rule out if there is any kind of a nasal bone fracture that has gone there. Now, what exactly is the view in which the X-ray is taken? Is it anterior view? Is it posterior view? Is it lateral view? Or is it medial view? So can we have...
Yeah, sir, I'm sorry to interrupt.
Yeah.
Before we move on to the answering session, there is a request from the technical side of Dr. Polaris. I request all of you to kindly rename yourself in your, in your webinar chat, because there are a
Yeah,
lot
too-
of
too many Abantis.
duplications. Yeah, there are duplications coming. I don't know, some kind of technical glitches happen. Kindly rename yourself. And also there are a lot of people answering. We are not able to rightly find out who is the one rightly answering first, or after that.
Right.
And
Right.
I can see a lot of people answering correct answers as well, even after the first session is over.
Yeah. So I think they can write the
And,
name and answer in the chat. I think that will be better.
Yes,
That is
yes.
good.
I think, can we go with the chat itself? Because if you people can put it up in
Yeah,
the chat,
sure.
it's
So,
easy for
so
us.
whichever person is in the chat first, and whoever is answering, maybe we can talk to that.
Definitely, definitely. So I think there is the first answer given was again lateral view, but I can see here the name is again Abanti Banerjee with a profile pic of a gray color T-shirt. Can you please
So anyone who's
unmute?
wearing a grey
Can you
color
please,
t-shirt.
yeah.
Yeah.
Can you
So,
please
right.
read? I mean, put up
Anyone,
your name
you-
also in the chat.
Yeah.
The Abanti who has a profile pic of two
Two boys.
boys standing together.
Anyone, because we'll be
Can you
happy to
just
know.
put up your name in the chat, please? Because that was the first answer we received. Okay, let's call.
Shanwas.
Yeah, I think
Yes.
yes.
Shanwaj Ahmad Laskar.
Yes.
Okay.
Can you, Shanawaz, can you have you on the mic if possible?
Yeah.
Yes, sir. Yes, sir.
Yes. So great, Shanawaz. You have absolutely told the right answer. Great. Now I would just like to ask you, okay, one thing. This is an X-ray that you said it is lateral view. Had it
Yes,
been an anterior view, why did you choose this lateral
No.
view? Okay, you are the intern. You want to choose a lateral view. Why not an anterior? Why not a posterior? Why not a medial?
because in the interview you so actually in the interview we cannot
Make
see
out.
the fractures.
Correct,
You cannot
correct.
see the fractures, of course.
Correct. So absolutely right. Like just see if the nose is right here, right? It is coming out. So anything in the nose would be better seen this way, or rather it will be seen this way. So there are so many structures which are just overlapping the nose here. So if you do anything from this side, it will all be overlapped, right? And that is why you chose something which can be easily seen, and because this is projecting out, this will be a different entity. And there you can see in the arrow also, you are seeing a small line, right? Can you make out, Shanawaz?
Yes, sir.
A small line in that X-ray
Yes, sir.
where the pointer is given, that is called as a nasal bone fracture. So what exactly you have done is basically you have actually learned through your one understanding of lateral view that is a nasal bone where that linear fracture is there, right? So this is a lateral view, and you are absolutely right. So congratulations for getting the right answer, right? So we'll now move on to the fourth scenario. Okay, so a patient is posted for appendectomy or appendix removal, and the surgeon has posted it early morning. And you are the resident on call, so you are called right away at 6 o'clock in the morning. The surgeon says, I will come after my coffee at 7 o'clock. So you have to go and take the patient to the operation theater and drape the patient and mark the incision over the abdomen where the surgery will be performed. Now you take a marker from the sister and you mark over the abdomen as shown in the given figure. So you can see there's something which is given there. Now, where did you place exactly the mark over on the abdomen? There is anteromedially on the right side, anterolaterally on the right side, posteromedially on the right side, or posterolaterally on the right side. What is exactly that you have done as a surgical resident? So let's see who has the right answer, Aishwarya.
Okay. Yeah. Again, sir.
A lot of
we
people have
this-
answered, but I think this
Yes.
is fastest finger first.
Yes.
Right.
Anterolaterally on right side. This was
Okay.
the first option that we received. May I know what is your name? Can you please type your name down there? Your name alone. Samreen
Samreen.
Fatima.
Yeah.
Okay.
So Samreen, can we have you over on the mic?
Yes. Samreen? Okay. Are you able to unmute yourself, Samri?
She's not able to unmute it. That's what she's saying.
Okay.
Okay. No
Okay.
problem, Samreen. We have noted that you have given the right answer. Can anyone unmute whoever has answered second? Aishwarya?
Yes, I'm checking that. After Samreen, we have Afshan.
Okay.
Yeah, Samreen. I think we got Samreen.
Okay. Yeah, Samreen, great. So, hi, Samreen.
Hi.
Yeah. So, congratulations for the right answer. You are the surgery resident on call. You did a great job. Surgeon is away and he's having his coffee. You did the right mark over on the anterolateral aspect. Now, can you just tell us what made you think that this is lateral and anterior? So what do you mean by anterolateral? Because here I have mixed two terms. Yeah.
It's because it's anterior because it's on the front side,
Right.
and lateral because it's lateral to the medial plane.
Great. That is simple and straight, and you get full points for that. So it is front. So you can also get these kind of mixed terminologies. That's why we have kept it here, right? So it's not like only the person will say anteriorly and medially. To make it simple, they can say anteromedially, or let's say posteriorly, posterior-inferiorly, superomedially. So it can be in different planes. So just don't confuse. It would mean the same thing as Ryan sir has already taught you. It's just mixing of two terminologies together, and then it becomes same. So great. We have got the right answer to Samreen. So thank you very much.
Yes.
Let's move on to the.
And a lot of and a lot of other students are also answering. Like
I
can see a lot of
Swati again.
answers getting popped up.
Yeah,
and
actually,
that means that Ryan sir has done a great job because students have understood
exactly.
one of the most difficult topics, right? Right. So many questions I've already asked you. We are all overloaded now, and this is what happened to you next, right? You just go down and you just put your neck down and observe and tell what happened with your neck. Flexion, extension, medial rotation, or lateral rotation. So let's see who have got the first answers. And you can see a lot of names coming up.
Yes. I think the first answer was again from I really don't know the person's name. It's flexion was given as the first answer. Can you please tell us what is your name? The first flexion that came after the previous question.
I think Afshan has written his name, or
yeah, Afshan. Afshan, can we get yourself unmuted?
Yes. I think Ghanshyam has already told the reason what I'm going to ask.
They're even answering the reason.
Right. So Ghanshyam has already told the reason. So I think you can get the answer from there. But Afshan, can we have you on unmute?
Yeah. Can you just raise your hand, Afshan? No worries. We'll make it possible. Can you just raise your hand, please? Yeah, I think we have got him. He's raising his hands.
Right. So can he unmute himself? Do we have Afshan?
Yes, we have him.
Yeah.
I mean, we have her. Sorry.
Oh, I'm so sorry. Yes, Afshan. Sorry. So, what made you think this is flexion?
Sir, because there is decrease in the angle, we are moving our head towards the trunk.
Great, great. So you're moving your trunk, you're moving your head towards the trunk, so that is flexion. Had you moved it away from the trunk laterally, I would say if I move my head like this, or if I'm saying, okay, I'm so tired, what do you call this then?
Lateral flexion. Lateral
Great.
flexion.
That is called as lateral flexion. Okay. That is what you need to understand. And right. And this is how you mix match and you learn so many things. And that is what we have in these case scenarios. Right. Great. So congratulations for the right answer. Let's move on to the next question. You are having this scenario every day in your life when you give exams, right? Everyone has this. You are sitting in your first year exams, tensed, Question number 1 appears and it is a bouncer. You don't have any idea what it is and you're utterly confused, but you notice that your friend who's sitting on your side is writing that answer well. Now you give a look, just see how the look you give to the person next to you, and you judge him for that. So what happened with your eyes here? Adduction of left eye and abduction of right eye, abduction of left eye and adduction of right eye, flexion and medial rotation of left eye and lateral rotation of right eye, or it is flexion of right eye and extension of left eye. So what exactly happened? Right? This is a common scenario. We all judge our friends who write the right answers. Right? So what is exactly happening?
I think the first answer was given by Swati.
Swati again? Okay.
Yes.
Yeah.
Swati, please tell your answer.
When we see the right eye is moving towards the medial plane. Left eye is moving away from the median plane. So towards the median plane means it is doing adduction, and away is abduction of the left eye.
Great. So that is absolutely the right answer, right? They are all moving in synchrony. So if one eye is moving towards one side, the other eye is also following that eye. So one is adducting, the other one is abducting, and that is absolutely the right answer. Now, that is what, when you read ophthalmology, this will become the same question there. So suppose if your eye is moving like this, so my right eye, lateral rectus is involved, and my left eye, medial rectus is involved, and they both perform the same action. This is what early clinical exposure is. Now you're understanding how you're putting up everyday thoughts and everyday clinical scenarios into learning this, right? So great, Swati. You have done absolutely wonderful. And this is also the right answer. You get one more to your bag. Right. So now we move on to the next question. Great. Now finally your exams are over. No more of first year trauma. And finally you are on a holiday and you plan to go for skydiving. The person in the plane makes you jump. And as soon as you jump out of the plane, your hands are. Now you just see, as soon as you've been thrown out of the plane, what has happened to your hands there? Okay. Now always remember, I was talking about what exactly has happened. Just notice what the hand movement is. It is flexed and laterally rotated. It is adducted and laterally rotated. It is abducted and extended, and abducted and flexed. So what exactly has happened? Can we have the right answer from, yeah.
First answer was from Afshan. He has answered it as fourth.
Fourth,
the second of, yeah.
It is abducted and flexed. Anyone else who wants to correct Afshan?
Yeah, a second answer, which was 3, was received from, again, a person whom I'm not sure what is the name.
Okay.
If I can just get your name there, please. The second person. Rudena. Can you just raise your hands, Rudena? Please raise your hand so that we can unmute.
Hello.
Yes, please.
Hi, Rudena.
Hi.
Yeah.
Tell your answer.
My answer is abducted and extended.
Okay. So now you're absolutely right. But if I ask you, did you focus on the mention of the hand there, and it is not the shoulder and not the arm or the forearm?
Yes, I did.
Okay. So what made you think that the hand is abducted and extended?
Because the hand was away from the medial, away from the median axis, so it is abducted, and it is because it is not folded, and the angle is increased between the forearm and the arm, so it is extended.
Okay, so just to correct you a little bit, the fingers, right? So
yes, the fingers are also extended.
To the middle finger, abducted, right? That is why. So this hand is very important to notice there. Okay, the arm will be a different domain, shoulder will be a different domain, the elbow joint will be a different domain, but the hand is being mentioned. So you have just the fingers, they have moved away. That's why his hand is like this, and he has extended his wrist joint. He has not flexed his wrist joint, he has extended it, right? So there is extension as well as abduction, correct? So you've got absolutely the right answer. Congratulations.
Just one thing I want to
Yeah.
come in. One thing all the students should keep in mind is this is the upper limb.
Yeah.
Henceforth, you will be referring to the upper limb in 3 parts. That is the arm, the forearm, and the hand. Arm, forearm, and the hand. Dr. Sanchit was very specific. Hand. This is not the. This entire part is not the hand. Just this part is the hand. This is the forearm, and this is the arm.
Right. So this is very, very important. So this, in somewhat of sometimes, like now we have got exactly the right answer. But sometimes when you're in a hurry in an MCQ and you know the answer, but sometimes you might miss out on some words and you might make a mistake in a hurry because you know that and still you hurried on that question. Later on you realize. So read the question carefully, whatever you are getting. Right? Okay, now let's move on to another question, scenario number 8. We all know this famous film, Bahubali, right? In this, Bahubali beheads the villain who happens to be the son of the real villain, and he happens to abduct. Now, this is really the abduct Dev Sena, right? Now, in order to get a revenge in this movie, the actor beheads the villain. The sword movement is in which plane? Sagittal, coronal, axial, or oblique, right? Now, this is something that I want the students to actually think and answer. Is it sagittal, coronal, axial, or oblique? So what is this kind of a sword hold or a sword chopping way? In which plane has he done that?
Okay, sir. I think this is going to be interesting because we have got
Yeah.
Samreen answering first as axial, Ghanishyam option 1 along the midline, Swati says option 3, Afshan says oblique, and there are.
So can we have all 4 on unmute? Please.
Okay, can we have Samreen, Ghanishyam, Swati, and Afshan?
Okay, because we have all these 4 answers and we have got 4 right.
Yes, we would.
So we have
want
4
to hear
people.
why they felt,
All
right?
are unmute.
Okay.
Yeah.
Yes. Okay.
Okay,
So we have
Samreen, we have Afshan,
Samreen.
we have Swati, and we have Ghanshyam, correct?
Yeah, the others will be joining, so we can ask Samreen first.
Okay, Samreen. So what is your answer, Samreen?
I think it's axial
Okay, what makes you think it is axial?
because it's a horizontal cut.
Okay, so the horizontal or the axial as per you, and also we can call it the transverse plane.
Yes.
Is the plane where Bahubali has chopped the head of this person. Okay, can we have the next person who wants to?
Swati is there. Swati
Yes,
is
Swati,
there.
can you do you want to add something on this or correct this answer?
Yes, sir. Yes, sir. It is
Okay.
axial. It is horizontal, and moreover, it is unequal divisions. One part is less, and the other part is.
Okay, fine. So basically,
Hello?
it is still you are following the axial plane, correct? So we have 2 axials. Anyone else who wants anything except for that?
Ghanishyam is there with
Anyone
us.
who wants to correct them or who wants to shed some light that this might not be axial or something else?
Afshan is also there with us. Anybody
Akshan,
who
you want to
wants
correct or
add?
Ghanshyam, you want to correct this? Anyone? Anyone in the audience who wants to correct this? Because this is an open ground where you can learn from each other. This is how you learn. So anyone else who has any other thing except for axial? Anyone else wants to go for it?
Rudina says oblique.
Rudina is saying oblique, right?
Yes.
Rudina, why do you think it's oblique?
Can we have Rudina unmute?
Hello.
Yes,
Hi.
yes, Rudina.
Because
Yes.
in the question they are not focusing about the cut, they are asking about the sword movement. So the sword movement was oblique.
Great. Okay. Okay. So now anyone else wants to do that? Or any other correction?
Other than this, I don't see any other answers. Like it's kind of repetition.
Okay.
Axial and
So-
oblique.
Okay. So the answer to the question will be axial. Okay. But I would say oblique is the right answer for the sword movement. Okay, so when they're asking about the sword, it is coming in this plane. This is an oblique line, right? But when they are saying that the head is being cut, then that is axial. Correct? So don't forget, axial, horizontal, transverse, they all happen to be the same. But when we are talking specifically about anatomical planes, oblique plane is not a plane in anatomy. It's not a plane in anatomy. So oblique plane can be discussed in terms of radiologically. Like radiologically, they might have an oblique plane, right? Or a fracture might be oblique. But a plane, when it comes to the plane of anatomy, it is always sagittal, coronal, median, and axial. These are the 4 planes. Now, can anyone in the audience, okay, just tell me that suppose we are, as Ryan sir told, that we are cutting the head like this, and then we are cutting the head like this, and like this, and like this, or suppose we are cutting the head like this at different levels. Can anyone tell me, is there any investigation which happens to use the same logic for images in the same form? Like if you cut it at different levels, can you tell me any one investigation that can be done this way? You're not actually cutting the patient, but the machine cuts you in different levels.
Please feel free to comment in the section.
Sir, could you repeat the question once again?
Yeah. So you have so one is real life cutting, right? Now, one thing is that you cut the whole body into different smaller segments in one plane, and you get images. Can you tell me what is the investigation? What is using this kind of a fundamental?
Yeah, I think Sangam has answered.
Yeah, Sangam has answered as
Biopsy.
full body MRI.
Great. So MRI, right? Magnetic resonance imaging, as well as CT scan, right? Computerized tomography. They are all having these small 1 to 5 to 10 millimeter cuts. So the machine already designs these 10 millimeter cuts. And what do? They start from above and they go down section by section, cutting the whole body in these planes. This is what will give you an overview of the whole radiology, how it is happening. And suppose if I'm a surgeon, I want my surgery to be done tomorrow. I said, okay, before the surgery, I want to do a scan of the patient and I want to look at the head in a coronal plane in order to see it. So now the surgeon will say, okay, get me coronal cuts. He will call the radiologist, give me sagittal cuts. What is he telling? He's telling, give me a plane, like a sagittal view of the brain, or a coronal view of the brain, or an axial view where he wants to see from the top. Correct? So this is how in different imaging modalities also you utilize these normal terms. This is what you will learn in radiology also. Right? Okay. Now let's come to the 9th scenario. That is the second last scenario. Very sad thing. A couple is very sad. And finally, after 10 long years of dating, together they broke up because of a stupid reason, because the man loved video games and he neglected the partner, because for him, video games are more important than a relationship. Now the heart broke. But in which plane did the heart break? Sagittal, coronal, axial, or oblique? Let's see who got the first answer.
I think we have again a person whom I'm not very sure what the name is, as sagittal. Can I know your name, please? The first person who answered. The first sagittal that comes after Ghanishyam has posted a comment. Can I know your name, please? Is it Shahnaz? Yes, Shahnawaz or Shanwal. I really don't know how to pronounce your name. Please raise your hands and unmute yourself, and please do let us know what your name is exactly. Okay, are you able to unmute yourself? Can you please raise your hands so that it's easy for us?
I think he's not able to unmute.
Yes,
Yeah.
ma'am.
Yeah. Hi.
Yeah.
Can I know your name?
Shahnawaz, ma'am.
Shahnawaz,
Okay,
right.
okay.
So what made you think this is sagittal? The heart broke into 2 pieces in a sagittal plane. Okay. So why?
It is parallel to it is parallel to medial plane.
It is parallel to the median plane, correct. So what exactly was the median plane? It is in the center. Sagittal means it is a little far on both the sides. You can cut it in any way, but it could be not as equal as a median plane. So median and sagittal are almost, it's same. It's in the center if you cut it like this, but it is a little away from the median plane, not exactly. And you can see these two halves are not very equal. They are, a little, one is bigger, one is smaller, and that is why we have kept sagittal as an option, right? Correct. So sagittal is the right answer. And let's move on to the last clinical scenario, right? So this is a difficult question. Let's see how many of you get it right. A 50-year-old male with chronic history of tobacco chewing came to the OPD with an ulcerated growth over the tongue. The final diagnosis made was tongue malignancy. Which area of the tongue is involved with the tumor mass? Is it the dorsal and lateral surface of the tongue, the ventral and lateral surface of the tongue, only lateral surface of the tongue, and posterolateral surface of the tongue? Right. So,
okay, so
can we have...
yeah. So the answers are already ready, sir.
Okay,
Samri has
yeah.
answered as 2, second option.
Okay. Who has answered 2?
Samreen.
Samreen has answered 2.
And we have Swati who has answered 1.
Okay. So
And,
can we have... Yeah.
huh.
So can we have one who has... nobody for 3 and 4?
1 minute, sir. So far, nobody has answered 3 or 4. It's all
Okay,
1 and
so
2.
either people are for dorsal and lateral, or it is for ventral and lateral. Okay, can we have 2 people who have the same kind of, who have different answers?
Give Sugandha a chance. I don't think she has.
Yeah.
Okay, I think Shanawaz says it's only lateral.
Okay. And we have, can we have Sugandha? Please, can you please unmute yourself here? Can you raise your hands so that it becomes easy for us?
Sorry, ma'am, for naming. Myself, Ayushman Mishra.
Okay, Ayushman, great. So what do you think the answer is?
Sir, my answer is dorsal and lateral because it's lateral because it parallel to the medial plane of the tongue, and it's dorsal means on the upper side. So
you are thinking that the dorsum of the tongue is the upper part of the tongue that is visible,
yes, sir.
And it is lateral means it is away from the midline. Correct?
Yes, sir.
Okay. So when it comes to the abdomen, does the dorsum of the abdomen is in front or ventral surface of the abdomen is in front?
Ventral is in the front of the abdomen. Dorsum is in the
Then
back
how
of the
come in
abdomen.
the tongue the dorsum of the tongue is in front and ventral is behind?
Because on the dorsum of the tongue we have a papillae. That is different scenario for the tongue. Dorsum is shown
Okay,
upward.
so that means it's an exception, we can say?
Yeah, yes. The exception to the tongue is dorsum is shown what we are seeing in the clinical scenario, and where taste buds are there, and ventrum
Correct.
is beneath
So this is the
tongue.
dorsum of the tongue, that is right. And it is also involving the lateral border of the tongue.
Yes.
You can see the dorsum also, as well as it is going laterally also, right? So this is the answer will be dorsal and lateral. Don't get confused to what the general dictum is, okay? In the tongue, what you're seeing outwards is dorsum. What is underneath is ventral or the ventral surface of the tongue. So don't get confused with this terminology. That's why I've kept it so that, you can know this and you don't confuse dorsum is back and ventral is front. And again, in the tongue, you get confused that I answered the wrong thing. That is why this scenario is, and great that you guys know it and you have finally done very well. So now we have done our rounds of the hospital and 10 cases are over. So this is how we are going to read anatomy. In every day, we are going to find answers in everything around you. So you can find answers even in yourself. Now, when you're talking inside the mess, when you're going back to college, don't talk to your colleague in a very generalized manner that, okay, pick up the cup. Flex your hand and pick up the cup. That should be the right thing, right? And whatever you are thinking, just find a reason behind that. This is how MBBS is learned. Try finding out reasons. If your friend is saying, okay, look at that side, you should think, why am I looking that side? If my friend is talking from this side, why my head is turning towards this side, not that side? This should be the clinical scenario in your everyday life. So you will be very happy when you come out because you'll be knowing each and everything about yourself. It's just about knowing yourself in detail, right? So the next segment, we will be covering about histology in detail. And we will be just going through the whole histological segment of anatomy, how histology, how you should read the cells, what is the microscopic picture like, right from basics till advanced, and try to make clinical scenarios. And we'll give you clinical questions to correlate in that too, right? So Ryan sir.
Yeah, so very happy to see such a active participation, and it also makes you feel happy that the students have been paying attention and enjoyed the session. We are open to suggestions. You can contact us anytime. You all want different lectures, you all want any other activity, you want any help. Dr. Sanchit and me are always available through Dr. Polaris. So hope to see you all in the next session. Over to Aishwarya.
So that was something like a mind-blowing session, because many people participated irrespective of that factor that it was dinner time. They would be hungry. I don't know, many of them have had dinner, but I really don't know. They actually participated in a very nice way, which I'm so happy about, actually. And there are a lot of people who answered and who couldn't, actually, we couldn't address them to the unmute session. But don't worry, we have so many of these kind of sessions coming up, and it's going to be really so much insightful for you all in the initial few days as well. So I'll have to tell few things. The first thing is that we had a session where a lot of people answered, but it's all getting competitive and really interesting. So the one person who answered the most and who actively participated is I think sirs, would you join with me if I say it's Swati?
Yes.
Yes.
So I think we can give a very interesting and nice prize for her. Swati, we'll be rewarding you with a free 3-month subscription of Dr. Polaris first year contents. Congratulations on winning this prize, and others, tighten your shoes and get ready for the next session so that you win this next time. And
the next session is going to be brain grilling, because it's all about pink and blue and everybody hates that. The histology is going to be the next segment, and I want people to participate and as much as come in and be a part of it, because you will understand more.
Even I'm waiting for it, because I would like to tell one important thing. Everybody, please note this down. From this week onwards, we are extending our Polaris talks to 3 days a week. So it is going to be on Mondays, every Wednesdays, and every Fridays. So we'll be coming back to you in the coming Friday, that is day after tomorrow. We'll be coming back to you. And also note, there is a small change in the timing. We are coming live at 6:30 p.m. So we'll be coming every Mondays, Wednesdays, and Fridays, 6:30 p.m. Okay, I hope it's clear for you. We'll be getting back to you in other platforms as well with the change in time and the dates. But keep tuned for amazing contents like this, and win exciting prizes as well next time. Congratulations to all of you who answered.
Congratulations to everyone.
Have a nice good sleep and a dinner as well. So thank you so much, sirs. Thank you everyone who attended.
Thank you,
Thank you so much. Thank you all the students.
All right. Good night to everyone. Bye.